Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 206 of our Pharmacotherapy MCQ series, which is a collection of clinical vignettes. And the first question reads, which of the signs listed below implies decreased organ perfusion in patients with shock? Is it A, altered mental status, or B, polyuria, or C, dry skin, or is it D, fever? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A, altered mental status, and I will tell you why. Although fever may be a sign of an infection, it is not a sign of tissue hypoperfusion. Clammy, and not dry, skin is a sign of decreased perfusion with vasoconstriction typically found in low-flow states like cardiogenic shock. Oliguria, and not polyuria, is a sign of hypoperfused kidneys in patients with shock. Altered mental status, e.g., obtundation, and confusion, is a sign of decreased perfusion of the brain in patients with shock. Please advance to the next question. And the next question reads, MJK, a 33-year-old female patient weighing 64 kilograms, presents to your accident and emergency department with a chief complaint of exhaustion, fever, myalgia, nausea and vomiting for the last 72 hours. Her pertinent vitals and labs include the fact that she is alert and oriented on 3 occasions. She has a body temperature of 38.4 degrees Celsius, a WBC count of 14.1 times 10 power 3 cells per millimeter cubed, platelets 222 times 10 power 3 cells per millimeter cubed, hemoglobin of 12.1 grams per deciliter, serum creatinine of 0.8 3 mg per deciliter, serum lactate 1.0 millimoles per liter, a respiratory rate of 18 breaths per minute, a blood pressure of 118 systolic and 75 diastolic. Her rapid nasopharyngeal polymerase chain reaction influenza swab was positive for influenza A. She has no significant past medical history. MJK was initiated on oral oseltamivir and admitted to the general medical ward. On day 2 of hospital admission, MJK's primary nurse noticed an acute change in her mental status with a Glasgow Coma Scale (GCS) score of 13. Other pertinent vitals or labs on this day include, a body temperature of 38.9 degrees Celsius, a WBC count of 18.2 times 10 power 3 cells per millimeter cubed, platelets 189 times 10 power 3 cells per millimeter cubed, hemoglobin 11.9 grams per deciliter, serum creatinine 1.31 mg per deciliter, serum lactate 1.6 millimoles per liter, a respiratory rate of 23 breaths per minute, a blood pressure of 88 systolic and 58 diastolic. MJK's primary team orders 2 liters of intravenous sodium chloride 0.9%, and her blood pressure on repeat measurement was 96 systolic 80 diastolic. Based on MJK's current clinical scenario, how would you classify her on hospital day 2, according to the sepsis-free definitions? Would it be A. sepsis, or B. systemic inflammatory response syndrome, or C. severe sepsis? Or would it be D. septic shock? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. sepsis, and I will clarify why. According to the sepsis-free definition, MJK meets the criteria for sepsis. Mean arterial pressure, abbreviated as MAP, is equal to × 2 multiplied by her diastolic blood pressure closed brackets plus her systolic blood pressure closed brackets, all divided by 3. This is equal to × 2 multiplied by 58 closed brackets plus 88 closed brackets, all divided by 3, which is equal to 68. She has a confirmed infection that is influenza A. Her quick sequential, which is sepsis-related, organ failure assessment, abbreviated as Q-SOFA score is 3. That is, she has a systolic blood pressure below 100 mm of mercury, an altered mental status, a respiratory rate above 22 breaths per minute, and her SOFA score is 3. That is, she has a MAP below 70 mm of mercury, a GCS score of 13, serum creatinine of 1.31 mg per deciliter. Therefore, her condition would be classified as sepsis. She does not meet the criteria for septic shock because her serum lactate is below 2 millimoles per liter, and she does not require vasopressors to maintain her MAP above 65 mm of mercury, since her MAP was responsive to fluid resuscitation. According to the sepsis-free definition, systemic inflammatory response syndrome is no longer recognized as a definition. According to the sepsis-free definition, severe sepsis is no longer recognized as a definition. Please progress to the next question. And the next question reads, OLS, a middle-aged female patient is admitted from your accident and emergency department with acute diverticulitis. So my question to you is, which of the antibiotics listed below would be the best choice for medical management of her infection at the time of discharge from the hospital? Would it be A. moxifloxacin, or B. cefuroxime, or C. clindamycin? Or would it be D. ciprofloxacin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. moxifloxacin, and I will explain why. Ciprofloxacin is inappropriate for this patient because it does not provide anaerobic coverage. Coverage for obligate anaerobic bacilli should be provided for patients with distal small bowel infections, i.e., OLS as acute diverticulitis. Clindamycin is inappropriate for this patient because of the increasing prevalence of resistance among the Bacteroides fragilis group. Cefuroxime is not appropriate for this patient because it does not provide anaerobic coverage. Moxifloxacin is the best choice because the patient's intra-abdominal infection is classified as a community-acquired infection, and it involves an extrabiliary site. These infections require antibiotics with activity against enteric gram-negative aerobic and facultative bacilli and enteric gram-positive streptococci. Additionally, coverage for obligate anaerobic bacilli should be provided for distal small bowel infections, i.e., OLS as acute diverticulitis. Moxifloxacin provides coverage for all of these pathogens. Please progress to the next question. And the next question reads, today is postoperative day 5 after small bowel resection in a 43-year-old female patient NKL, with trauma following her involvement in a serious motor vehicle accident. She has no significant past medical history. Her pertinent vitals include a maximum body temperature since the surgery of 38.5 degrees Celsius, and a heart rate of 130 beats per minute. NKL has a loculated fluid collection near the anastomosis. So my question to you is, which of the regimens listed below would be the most appropriate empiric antimicrobial therapy to use until NKL's culture results are reported by the clinical microbiologist? Would it be A. Piperacillin, tazobactam plus fluconazole? Or B. Piperacillin, tazobactam plus micafungin? Or C. Piperacillin, tazobactam plus vancomycin? Or would it be D. Piperacillin, tazobactam? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Piperacillin, tazobactam. Piperacillin, tazobactam is appropriate because this patient has a healthcare-associated intra-abdominal infection. Healthcare-associated infections require treatment with antibiotics that have an expanded spectrum of activity against gram-negative aerobic and facultative bacilli. Piperacillin, tazobactam provides this coverage. Piperacillin, tazobactam plus vancomycin is inappropriate for this patient because empiric treatment for methicillin-resistant Staphylococcus aureus (MRSA) using an agent such as vancomycin is recommended only for patients with healthcare-associated intra-abdominal infections who are known to be colonized with the organism or who are at risk based on prior treatment failure and significant antibiotic exposure. Vancomycin is also recommended for treatment of proven intra-abdominal infection due to MRSA. Piperacillin, tazobactam plus micafungin is inappropriate for this patient because antifungal therapy is recommended only if Candida is grown from the intra-abdominal cultures, not for empiric use. Fluconazole is appropriate if cultures demonstrate the presence of Candida albicans, and an echinocandin should be used for fluconazole-resistant Candida species. Piperacillin, tazobactam plus fluconazole is inappropriate for this patient because antifungal therapy is recommended only if Candida is grown from the intra-abdominal cultures, not for empiric use. Fluconazole is appropriate if cultures demonstrate the presence of Candida albicans. Please proceed to the next question. And the next question reads, JTR, a 62-year-old male patient is postoperative day 0 after pancreaticoduodenectomy. His current medications include levothyroxine 150 micrograms orally in the morning, extended-release metoprolol 50 mg orally once daily, and ranitidine 150 mg orally twice daily. So my question to you is, which of the following medication adjustments would be the most appropriate while JTR is unable to take anything orally and remains nil by mouth in the surgical ward? Would it be A. Convert the 50 mg oral metoprolol dose to 12.5 mg IV 4 times daily with close blood pressure monitoring? Or B. Convert the 150 mg orally twice daily ranitidine dose to 150 mg IV thrice daily? Or C. Withhold levothyroxine therapy for a few days until he is able to take the drug orally? Or would it be D, give the same 150 micrograms levothyroxine dose IV once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, withhold levothyroxine therapy for a few days until he is able to take the drug orally. Giving the same oral levothyroxine dose by the IV route is inappropriate because 50% of the oral dose should be used by the IV route. Withholding levothyroxine for a few days is the best option because levothyroxine has a half-life of 6 to 8 days, and withholding the medication for a short period until the patient is able to take it orally probably will not cause the patient harm. Converting the oral ranitidine dose to 150 mg IV thrice daily is inappropriate because it is excessive, because 50 mg IV thrice daily is a more appropriate dose. Metoprolol 12.5 mg IV 4 times daily is not appropriate because this is not the correct conversion from oral to IV metoprolol, which should be 2.5 to 1 oral to IV. The correct IV dose is 5 mg 4 times daily. Please progress to the next question. And the next question reads, AJO, a middle-aged patient is receiving continuous tube feedings via a percutaneous gastrostomy tube for nutrition support. So my question to you is, which of the following oral medications has a pharmacokinetic interaction with AJO's enteral nutrition? Is it A, digoxin, or B, ciprofloxacin, or C, cotrimoxazole? Or is it D, phenobarbital? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B, ciprofloxacin, and I will explain why. Phenobarbital is physically compatible with enteral nutrition products. Trimethoprim, sulfamethoxazole is physically compatible with enteral nutrition products. Withholding tube feedings for 1 hour before and 2 hours after ciprofloxacin administration is recommended because enteral feedings decrease the absorption of fluoroquinolones. Digoxin is physically compatible with enteral nutrition products. Please progress to the next question. And the next question reads, which of the following statements listed below, regarding the use of albumin in patients with sepsis and septic shock is correct? Is it A, the SAFE trials showed a mortality benefit from the use of albumin instead of normal saline in critically ill patients? Or B, the Surviving Sepsis Campaign guidelines recommend an initial fluid challenge of 30 ml per kilogram of colloids, and albumin is preferred? Or C, albumin should be considered for fluid resuscitation in patients with septic shock when substantial amounts of crystalloids are required? Or is it D, the addition of albumin to crystalloids for fluid replacement in patients with septic shock and serum albumin below 3 grams (dl) significantly improves mortality? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, albumin should be considered for fluid resuscitation in patients with septic shock when substantial amounts of crystalloids are required. In the albumin-Italian outcome sepsis, abbreviated as ALBIOS, study, adding daily albumin replacement to crystalloids to maintain a serum albumin greater than 3 grams per deciliter did not significantly improve mortality compared with crystalloids alone in patients with severe sepsis. The Surviving Sepsis Campaign guidelines recommend initial fluid resuscitation with crystalloids, not colloids, and consideration of the addition of albumin in patients who continue to require substantial amounts of crystalloids to maintain adequate mean arterial pressure. The saline versus albumin fluid evaluation, abbreviated as SAFE study, showed no significant difference in mortality between the albumin and normal saline groups. Please proceed to the next question. And the next question reads, TNT, a 46-year-old male patient presents to your hospital with the following chief complaint and labs. Necrotizing pancreatitis, altered mental status, serum lactate 7.2 mmol per liter. At your accident and emergency department he received 45 milliliters per kilogram of crystalloid fluid resuscitation but ultimately required vasopressors to maintain a mean arterial pressure (MAP) above 65 mm of mercury. TNT is currently receiving continuous infusions of norepinephrine, epinephrine, and vasopressin to maintain MAP above 65 mm of mercury. Empiric broad-spectrum antibiotic therapy is planned. So my question to you is, which of the antibiotics listed below would probably not require dosage adjustment due to the increased volume of distribution that commonly occurs in critically ill patients with septic shock due to the capillary leak syndrome and the large volume of fluid administered for fluid resuscitation? Would it be A. tobramycin, or B. meropenem, or C. ciprofloxacin? Or would it be D. piperacillin, tazobactam? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. ciprofloxacin, and I will explain to you why. Beta-lactam antibiotics, e.g., piperacillin, tazobactam, are hydrophilic medications, so they are likely to be affected by increases in volume of distribution in critically ill patients with increased capillary permeability and fluid resuscitation. In these patients, high rates of therapeutic failure and resistance have been reported for beta-lactam antibiotics if dosing strategies are not adjusted for these alterations in pharmacokinetics. Fluoroquinolones, e.g., ciprofloxacin, are lipophilic medications, so they are unlikely to be affected by changes in volume of distribution and fluid resuscitation in critically ill patients. Carbapenems, e.g., meropenem, are hydrophilic medications, so they are likely to be affected by changes in volume of distribution in critically ill patients with increased capillary permeability and fluid resuscitation. In these patients, high rates of therapeutic failure and resistance have been reported for carbapenems if dosing strategies are not adjusted for these alterations in pharmacokinetics. Aminoglycosides, e.g., tobramycin, are hydrophilic medications, so they are likely to be affected by changes in volume of distribution in critically ill patients with increased capillary permeability and fluid resuscitation. In these patients, high rates of failure and resistance have been reported for aminoglycosides if dosing strategies are not adjusted for these alterations in pharmacokinetics. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 207.